today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. Please note for the record, Dr. Michelle Allen is representing Dr. Mitchell Katz in a voting capacity. So first, I'd like to propose a motion to adopt the minutes of the Finance Committee meeting held on October 17th, 2022. Do I have a second?
Second.
Okay. Dr. Allen? Oh,
Yes.
okay.
Approve.
Ms. Lowe?
Yes.
And Dr. Peñamora?
Yes.
And I vote yes, so the motion is adopted. And we don't have any resolutions today, so the floor is the finance team. John, if you could give us your update, please.
Yes. Thank you. Can you hear me fine?
Yes.
Well, thank you for your time. I'd say, the system, as we look how we're doing through November, the data's in, we feel like we're stable. I'll say, there is a feeling of, confluence of pressures, right, that are out there that we'll go through that I think, we're starting, to feel a little bit. I don't think we're alone. I think many other safety nets, as they're looking at how they're emerging, from COVID, are feeling the same sorts of pressures. I would even say we're maybe even doing a little better from some of the data that I've looked at, but nonetheless, I think that pressure is there. The system closed in September with 550 million or 24 days cash on hand. I looked today, I think we have 445 million in the bank today. We'll talk a little bit about, that trend and where we see it going. The net budget variance was a positive 46.5 million, so to the positive 1%. We are starting to see direct patient care receipts starting to flatten or plateau a little bit. There's obviously more work for us to do, and we have plans in place, to further improve our patient care, collections. But we are starting to see it flatten out a little bit. We do have a hold on some claims in South Brooklyn due to the names change, but we fixed that glitch, and those monies will flow next quarter. And then there's some ups and downs that we had with Metro Plus as it related to the UPL payments that we've sorted through. Patient care volumes are returning to the pre-COVID levels, which I think is good, and this is where I think we feel pretty comfortable. We're 1% behind FY20 in discharges and inpatient discharges, but I know as of today we're very busy. We were out at King's on Friday, and they were very busy at King's, especially in the ED. 3% ahead of where we were on outpatient visits. So those are all good signs. Revenue base still performing very well. We feel very good that all the work we've done is holding as a system. So all those are good indicators. Next slide. You want to do that? You want me to do it? Okay. So next slide. So we're estimated, as I said, close November with 400. And we're at 445 today, so I think we're doing fine there. Again, our work, as cash starts to tighten up, we have to work more closely with the city, but again, I think nothing alarming or concerning there. Next slide. There's managing risks. I think, wage pressures is really certainly something being felt by industry in general, but I think most particularly the hospitals as a group are feeling that pressure. There is some evidence out there that maybe inflation is starting to abate, and perhaps that will help, with some of these, cost and wage pressures. Nursing costs in particular are up. We still have a pretty heavy reliance on outside contract nurses, which is, driving our costs about $100 million higher than we had budgeted for, but we're looking at that very closely. We've talked about Medicaid research. This was all tied to the response to COVID. The federal government put a pause on the recertification process. We keep hearing different dates. It keeps getting pushed out. But there's millions of folks that are on the Medicaid rolls that once they start the recertification process again, that could pose a risk to the plan, because as people, decide to either they're not eligible for Medicaid any longer, or hopefully, right, they'll find another insurance product with Health First, Metro Plus, and we retain them. So there's a lot of work going on here, but I think the Medicaid recertification rate estimated by Health First is over 100,000 people a month, just to give a sense of the magnitude. And the last number I heard was over 1.5 million individuals across, the state need to go through a recertification. So that's just a ripple in the system. We're working very closely with our partners at Health First and Metro Plus to make sure that as our patients' date for recertification comes out, that we have systems in place to reach out to them and help facilitate them being re-enrolled. I think, part of as the economy's gotten better, some of what we're hoping for is that perhaps individuals that aren't eligible for Medicaid will be eligible for the essential plan, and the rates are much more generous, with the essential plan or even, a commercial product. So, but our goal is to hopefully have them stay with health and hospitals so we can navigate our way through this recertification. State and city budgets, the city's reported a $2.9 billion gap for the coming year. They've initiated through different steps with the city agencies as part of the budget process. The fine savings will go through what we call the PEG plan here a little bit. On the state side, state budget picture, I think they reported a $150 million gap for next year, which is really nothing, but that gap grows to over, I think, $3.5 billion in the following year. And I think there's some pressures on the global cap that will have to be part of, negotiating the budget process next year. So those are all things, we keep our eye on. Slide. Oh, I will say that we did, I think it was reported in a publication about our first quarter results, comparing 21 to 22. I think it was in Becker's, perhaps. It indicated that we were on a year-to-year basis down $180 million. We were at $58 million to the positive last year. I think we reported a down of $124 million. Again, this is I think one of the things that we want to perhaps come back to the Finance Committee and bridge the gap a little bit between how we report on a cash basis versus what we're seeing on an accrual basis. We're very comfortable on both sides, talking about the numbers from those two different perspectives. Both are obviously very, as it relates to accounting practices, cash versus the accrual process, both accepted standards. We've always used cash. The city's on an accrual basis. The state Medicaid program's on a cash basis, right? But I think for us to kind of be able to crosswalk between the two and do some reporting here, right, we think is a good idea. We're even contemplating amongst ourselves, should we switch over to an accrual-based system? We want to think through that very carefully. My concern has been that, we need to do a better job of getting a more, stable streams of revenue. You've heard me talk about UPL and DISH. Some of my reluctance is taking our eye off cash. I'll feel more comfortable if we can kind of embed those revenue streams more. So, but more to come. But I think if we really had to, explain what happened year to year, I think most of it can just be explained by the fact that, related to, we took an adjustment. We explained last time, as we did bring in extra UPL money last year, right? We wanted to be conservative, and we took a DISH adjustment downward because there's this concept of the facility DISH caps. And I think there's other transactions, David could go through it, but what primarily drives that year-to-year change is that we did take a DISH cap adjustment, reflective of the additional UPL money.
Right.
So that's.
Yeah, I think because you're exactly the purpose of why you want to stabilize your revenues makes the cash and accrual make even more magnified than it usually is, in terms of telling me perhaps seemingly different stories at some point, right? So
Right.
I think it would help the Finance Committee at some point to do some kind of crosswalk when you guys are ready. I don't know, it means that you have to shift to accrual, or maybe it does. That's obviously your decision. But I know we are planning a cash flow discussion, and maybe we can add this one to next year too.
That's what we thought too, right? We thought those two would go good together. We can talk a little bit about how our cash comes in, the volatility of that, steps we're taking to smooth that out, and then we can have a discussion about the crosswalk between the two, and maybe even facility DISH caps if we really get
Take a whole day.
Any other opportunities? I mean, I'm going to go upstairs and talk to 35 doctoral nurses who probably could generate some income for us. So, well, maybe I won't talk about that today with them, but I have that feeling that we should be expecting better productivity.
Yeah, no, I think, we're very proud of the fact that we embraced, the nurse model, right, early on, right, before many other systems. And we have that built in now. We're trying to do a better job, but we have that built in operationally, right, and also budgetarily. And we feel good about that, right? We want to make sure that our nurses have enough support, our patients have enough nurses. And what we say within finance is we always want to make sure that there's enough resources at the bedside to provide the care that day. And we think the nurse ratio model allows us to do that, right? And we didn't used to have that. And we're trying to make improvements, on that model and use it in, not just inpatient, but, throughout health and hospitals. So
Certainly, we have to put an investment before, and we have such good models coming up with housing as well,
yes,
and which was always supported by the PPACA, but not done.
yep.
So hopefully, we'll be able to generate and cover
You say you
the
have-
expenses of these
you have a
wonderful
I have two clarifying questions.
um, occurrences.
Yes.
I have one question,
You had your hand raised.
really quick. On the Medicaid recertification, is it a problem? Is that a problem that every health plan is going through? And I guess it's at the end of the day, the state will have this group of folks that don't get the care that they need, right? Because they don't get recertified. So how does that? Are we different from other plans on how we do it, or?
Yeah, I don't think anybody's different, right? I mean, it's a process, so the federal government, I think rightfully so, decided in the midst of COVID it wasn't a good time to continue the certification process, right? They want everybody to be as insured as they could. They've done this in past disasters. They couple that with an enhanced FMAP, right? So the federal government actually pays the state additional money during the COVID period, and that helps them actually pay additional money because these folks would otherwise come off, the Medicaid rolls. But I think, all health plans, including Health First and Metro Plus, have financial models that we've also incorporated into our fiscals that makes estimates about how many people, when they come up for research, just may no longer be eligible for Medicaid, right? Because they've gotten a job, right? Or they may be eligible for the essential plan, right? Because their income levels have gone up, right? So these things will all, be at play, but it can be disruptive. I think states are trying to figure out how to smooth that process out, and we'll have to work closely with them. But we watch it because, again, we're a sub-capitated oriented organization, and when a person leaves that sub-cap arrangement, we lose the entire revenue stream, not just their eligibility.
And do you think that inflation is impacting, will impact that? Is that estimate take into account the fact that
Yeah.
wage pressures have been going up? So I imagine that some people, even though you have less money,
Yeah, I think
real money,
well, jobs are coming back, right? So the job market will be a key indicator in terms of, making some estimates about what the roles eventually will look like. I think health plans have some concerns that the people that could leave the roles are ones that are low utilizers of service, right? That can have a financial impact if somebody who's a low utilizer of service, is recertified out of the Medicaid program, right? That can have an effect. You'll hear us talk about, how well we're doing in the risk pool, right? Some of that is, the fact that we have individuals that are low utilizers and we're, benefiting as a result. So there's a lot, right, that will unfold here, right, as they initiate the research, process. When that happens, we're not sure. I think we've heard February, we've heard March, and there'll be a lead time between the time they make the decision and they start the research.
Thank you.
Fanny Husky?
In here, I think you mentioned PEG, and what I was wondering, the mayor's office have requested most of the agencies to reduce their budget. Are we under that directive as well as a PEG?
Yes, we have a slide in here, I think it's 14 million that grows to 20 million. So it was, we thought a fair, PEG level, for us at Health and Hospitals. But we've met the PEG, we've submitted our plan, it's been adopted, by OMB. But yeah, so we have a slide, we'll go through the details there.
Okay, so that had that. And the other question is, when you said, I think, if I remember correctly, 24 days cash in hand, is that correct?
Yeah.
Does that include test and trace funding, or that is separate? It's only what we have in terms of the hospital system without test and trace?
Yeah, each needs proper. We try to keep those sets of books.
Okay, so this only is
Yeah.
hot test and trace. Thank you.
Why don't you go ahead?
Okay, who's up?
Sure, Selena Tyler, Finance. We're up to the financial performance slide. There you go. So you see that we ended September with a net budget variance of 1% to the positive. That's 46.6 million, and that represents the difference between overspending and expense of 70 million. And overachieving our revenue target by 116 million. And the following slides will get into some of the drivers of those budgeted variances. Next slide. Okay, so starting with revenue, there's ins and outs between our inpatient volume and rates and tax performance, but the big story with revenue is our risk pool performance. You'll see that 109 million of the positive variance is attributable to our Metro Plus and Health First risk pool performance ahead of target. Roughly 52% of that is from prior year Metro Plus reconciliations that were unanticipated in the budget target. The balance of that comes equally between Metro Plus and Health First, 10 member per month risk pool performing higher than the budget assumed. This means that the average enrollee we're collecting more risk on average for each. That can be driven by a number of reasons, partially due to the fact that, to John's point earlier, some of our lower utilizers are enhancing our risk pool, and also due to targeted work that's being done by our value-based payment teams and our facility partners to manage risk pool performance, and they're doing a deeper dive on what's driving the PMPM improvement there as well. Any questions before we go to expense?
When you mentioned the risk pool, what comprises that risk pool?
Sure. So we have Health First for all lines of business, and for Metro Plus for our Medicaid and commercial lines of business. That means that all of our members who are attributed to our providers as well as our community providers, we have a risk sharing agreement with Metro Plus and Health First.
Were they individuals who were succumbed by COVID mostly, or would you know that?
Yeah. So some of them likely were COVID, and also as we get further out from COVID, that's probably also a driver of the fact that our medical expenses are down coming out of COVID and those reconciliations. So yes, I would say some of the patients are COVID, some aren't.
Thank you.
We'll move on to the expenses. So a few things driving expenses here. You'll see COVID expenses are still part of our picture here. Some of this is catch up on prior year payments hitting this year. We also have our agency temp staff coverage, which has been an ongoing issue here. And then we do have a bit of underspending on our other discretionary spend. It's partially due to needing to catch up on our billing timelines and some other issues in AP that are being resolved for speeding up bill payment. And I don't know if Micheline, if you want to add to that.
Yeah, I mean, basically, as you mentioned, although it shows that we are 34 million better than budget, we're doing a lot of work right now to make sure that we are up to date with all our bills. So it's a combination of moving more and more to electronic fund transfers with our vendors, transitioning more of them there. And also, we're doing some updates on our unit costs as changes happen on the supply chain side, which with both of those things, we will be seeing likely more of our discretionary spend as the fiscal year unfolds.
Do we have any hopes that there will be more funding streams for the sequela brought on by the long-termers and all of that. I'm thinking that that should be expected at some point. That we don't have a resolved COVID event, that there will be long-termers and various age groups. Am I dreaming?
Say that again, Barbara? Say that, can you repeat that?
There are so many people who are going to live with the aftermath for a
Long
long time,
COVID.
and symptoms
Long
and such.
COVID.
Yeah.
Yeah, the problem is that if people don't know they have it, I think it's underdiagnosed.
We're gonna I mean, we're already documenting that,
Exists.
everywhere.
Yeah.
In the
Yeah.
reports and other kinds of literature. So I'm just thinking that perhaps we
I think it's a
should
very
be
good point.
expecting.
I think it's a very good point. I know that the actuaries that, set the Medicaid rate will look for those sorts of trends, when they learn about it in the literature, and will try to, quantify it, and to the extent that it's significant enough, make adjustments in the rates that eventually, get passed to us. So I think it's a great point. I think we're still learning more. Obviously, there is long COVID. What are the long-term, implications of providing care to long COVID? How much does that cost? I'm sure there's actuaries looking at that closely.
Besides Medicaid, the private insurers are getting off the hook on a lot of issues. They've raised their rates on certain things. I know personally for my eye drops. I'm totally out of my money to buy my little wraps now. So it's really something that I think, we are a large institution and a well-known one for our performance. It's not only Medicaid. I'm hoping that we will see better
Sure.
payments.
Yes.
Okay,
Freeman.
this last slide here is just giving you a view of year-over-year revenue. To John's point earlier, our overall inpatient outpatient revenue is slightly down from prior year, largely attributable to the hold impacting the cash flow for Coney Island, or South Brooklyn now. And you'll also notice that the light blue, lightest lavender box to the top, that's the risk pool performance year over year. We're doing 62 million better than prior year, and again, largely due to that PMPM as we come out of COVID. Further out of COVID, our Medicare risk pool with Health First is doing better than prior, as well as our enrollment being higher than prior year as well.
Thank you. James? Or John?
So I think John mentioned this earlier, but just in terms of the PEG that was part of the city's November plan. So OMB put out the November plan on Tuesday, November 15th, since we last met. And the plan, as John noted, they have cuts for all agencies, with 3% in the current year, growing to 4.75% in FY24 and out. We were able to work with the city and find a number of efficiencies, largely on the administrative side, that will ultimately have no programmatic impact. But the result for us was a reduction of $14 million, as John noted, in the current year, growing to $19 million next year, and then $21 million in the out years.
Do you have any questions?
No, that's what I wanted
Okay.
to know. I
All
think that's okay.
Thank you.
Okay, so for revenue cycle performance, I wanted to show you what we call the revenue cycle STAR report. As many of you know, we developed the STAR report to provide facilities a snapshot of revenue cycle performance. I say revenue cycle performance, but there are STAR reports for multiple areas within finance. We set the targets and measure performance against these targets every month. We do this at the facility level. What I'm showing here is the roll-up for all facilities. As the performance improves, we raise the bar and we increase the target. So if we get really good at something, we increase our goal. Or we find new targets. We find new areas of opportunity to focus on. On the left side, there's what I'm showing is a progression from when we first started measuring in fiscal year 19, where we started out with less than a full star, to the close of fiscal 22, where in aggregate we achieved 4 stars. On the right side, we're showing the most current period STAR report, which is through September. And we're continuing at 4 stars on across all of the acute care hospitals. Of note, we've increased the financial counseling target. So as I noted earlier, that if we achieve our targets, we increase the bar. So we've increased our financial counseling target and combined the target for inpatient, outpatient, and emergency department, and our target is 95%. We're not quite there yet. We're at 89% in aggregate, but that's actually improved performance over prior periods. We've been at that, and it's exceeding that 95% target consistently on the inpatient, but have been increasing our coverage rate on the outpatient side. Another area that I wanted to point out is candidate for billing days, or CFB. Those are claims that for where the patient's care has been completed, they've been discharged, but the bills aren't yet ready to go out. And our candidate for billing days, if you look on the left side, the first time we reported it, we ended the fiscal year at 8.2 days in candidate for billing. Our current target is 3.8 days, and this period of September, we achieved 3 days. So that's an area that we have continuously made improvements and reduced, in this case, lower is better, reduced our target. We've added a new target of AR aging. We've not consistently have not achieved our AR days target, which is how many unpaid bills basically remain in our accounts receivable. Our target is 45 days. So to help keep us accountable to actually achieving that, we added a new target of AR aging, where we're aiming for less than 21% of our AR to be greater than 90 days old. The 21% was selected as an internal best practice. So we're looking for everybody to achieve that internal best practice, and then we'll take the next step and move to industry best practice, which is just a shade better than that. Any questions?
Questions? What do you think is making the AR so hard to get down?
That's a lot of things.
Okay.
We have struggled with patient receivable, with self-pay AR, and there's a whole lot of things mixed up in that. We take a really cautious approach with the patients.
Yep.
So some of it is that, some of it is vendor relationships and making sure that we're handling that correctly. There are a couple of other aging issues related to some historical issues that we have with a couple of payers, Medicaid in particular. I guess high-cost outliers would be one, that we have a whole bunch sitting out in aging high-cost outliers, a lot with fee-for-service Medicaid, some with managed care plans. I'd say those are probably the two biggest things right now that we're struggling with.
So when it's the plans that aren't paying, is that because we're not providing the proper information, or is it, I can understand the self-pay and having difficulty there, but we can do something about it, in other words.
Yes. It's probably a combination. We're working really closely with the state to go through, they have some backlog on their side, quite a bit, that it's possible that there are claims in there that there was something we could have done about and handled better, but we're not getting the information back in a timely manner. So we have, bi-weekly phone calls with them and their vendor, and really trying to work through and understand what's going on. I think we can't really answer that question yet.
Yeah, outliers is a good one. I will say we do have communication with, with the department, where in the past we didn't. I mean, we'll take outliers. We never even used to get paid for outliers, right? So now we do get paid for them, going back to 2019,
yeah.
right? But when we look at the process, maybe we weren't quite sure. Is it because we're new to the outlier business, right? That it's our fault that they're getting stuck? the state has this group called iPro, who's like a vendor of theirs that's important in the is it stuck with them? Is it stuck with the health department? So Margie, now at least everybody's at the table looking at the same set of claims, trying to figure out where the problem is.
Right.
But it's a lot of money,
Yep.
right? And it's owed to us. And we've committed to them that, what they learn from us and what we learn from them is something that we will fix. But at least we're at the point where we can have, a discussion. And it's, again, it's a lot of money that, we feel like we're owed, and we have to figure out why is it stuck. So,
It just seems to me that there are too many corporations who are taking advantage of this time to leach out, take money away, but not pay.
right.
And I don't know what to do about it, but it hurts certain segments of population and not others.
Right. No, I would be much more concerned if they were just ignoring us, right? And they're not, right? So I will give them,
Legal.
the benefit of that, but, we do, in a nice way, but forceful, saying we have to resolve this. And it affects our finances and obviously our statistics here, so.
Okay, well, I'm glad your eyes are on the ball, so
Yeah.
thank you. I think there's some.
On test and
Test and
treat, just a quick update in terms of our finances. So for the first quarter, we committed about $112 million. Our budget remains for the full FY23 to be $288 million. The large majority of which is for testing. You can see it's about $245 million on the table. And just a note, as it's been for the last couple of years, OMB continues to provide the funds through the MOU to cover the expenses that we've been incurring.
So James, does that mean that is tracing done? No more, because there's no dollars allocated here for tracing.
Right. We've now transitioned to test and treat. So
Yep.
we've got the units that will test and then provide Paxlovid if eligible and appropriate and clinically appropriate. But we're moving, we've moved away from the
This is for treat encompassed here or in this table?
Yes.
Yeah, okay. And what about vaccine? Is that still under this MOU or not?
Vaccine is still covered by the MOU. As you can see, we're not anticipating costs because we're no longer running those larger sites as part of the T2 operation.
Right.
But if that was needed,
Okay.
it would still be covered by the MOU.
Any other questions from members?
No questions.
Great. Well, thank you, guys. Great work as always. I know there's you talked about a lot of risks there, John, that are difficult, but thank you for all the good work.
Thank you.
So if there's any old business, any new business, there being no further discussion, meeting adjourned.
Thank you. This meeting is no longer being recorded.